Okay. So next week is going to be your exam, and you'll have your exam the whole time. So take your whole time. I know I've talked with some students and they rush through the exam. Don't rush through it. You have from 4 to 7 to take your time. Utilize your time. Read your questions. Um, think about what they're asking you. Think about, are they asking you about mom? Are they asking you about baby? Are they asking you, um, what is the first thing that you should do? What is the, the most important intervention? And I don't like to use this term, but my, one of my colleagues and I used to use it a lot when we first taught in 150. Ask yourself, what is going to kill the patient first? Look at that. Is their blood pressure tanking and they got a lot of pain? Okay. What would kill the person first? A blood pressure of 180 over 100 or pain 6 out of 10? Pain, the blood pressure, right? And then now you guys are like, I don't want to answer any questions. But yeah, so just think about that. And because I think priority questions are tough. And that's what you're going to have a lot of in NCLEX is priority questions. A couple of other things, the exam will be a little bit different with 100 questions. You'll still have your 100 questions. They'll be mostly multiple choice. There will be medical math. There'll be SATA. I put a case study in there. So the case study will follow you through a client and it'll take you through that client and you'll be making decisions on that client. It could be a med math question in that case study. It could be a fill in the blank, it could be a SATA. So it could be a prioritizing question. It's not a difficult, honestly, it's not difficult. Most of my students in previous courses have done well with the case study. I don't make it difficult, but I put it there because when you go to take your NCLEX this summer or towards the end of the summer, I want you to be as familiar with all the different types of questions that will be thrown out to you now, so that when you sit down and take your NCLEX, other than being an absolute basket of nerves, you'll at least have recognized these questions. So that's my method to my madness. And then you're the last class to take it, so you don't have to wait as long. But just be patient with me as I go through and do my grading, which you were in the past. So any questions about the exam for next week? I did post a study guide. It's there. So if you have not been in Canvas, the study guide is posted. So any questions?
Professor Gannon, are you going to repost this for us to view later to actually watch the recording again?
I usually don't, unless I'm recording it, or doing something else. As long it's up to everybody else. If you guys are okay with it, it's just, whatever works. I know the other ones have been recorded, so it's up to you guys if you feel comfortable, with it. I mean, I'm sharing it with my online, but just have to remind me. But any questions about the exam or anything? Any questions before because then when I'm done, I'll hopefully give you guys some time to work on your projects a little bit with your group. All right, everybody can see my screen, right? Everybody can see my PowerPoint? All right, so what we're going to do, the major focus is on chapter 12. So the major focus will be chapter 12. There will be a little bit with chapter 13. So that's probably why you were like, oh, thank goodness. She only gave us a quiz on one chapter this week. So there's a couple of things I'll talk about, but the major focus is on postpartum. We're going to talk about postpartum, and we're going to talk about contraception. I have 2 little activities to do, and then I'll go over chapter 13, which is very brief, and go over the NCLEX questions that were in your PowerPoint and take any questions from the group and review your project and kind of let you guys go. So that's my plan for today. All right, so the first thing I want to do is go over the quiz. Can everybody see it? Yes? Okay. I minimized your pictures. That's why I didn't. Okay, so. All right, the first one, the nurse is changing the pad of a postpartum client and notes that there is blood only on the tissue when wiped with 1 to 2 inch stain. The nurse documents this as?
Scan.
Yeah.
Sorry, why is this scan? It says less than 1 inch is scanned.
We'll go back to that. If you hold through, I'll go back. If you, I'm using, this is all based on the textbook. So if you look at the textbook, that's how they described it. So I'm in the quizzes, I use the textbook questions. Number 2, an important nursing action that allows for the identification of potential complications such as uterine atony is?
Assessing the fundus.
Yes. Colostrum is?
The clear yellowish fluid that precedes milk production.
Got it. Contraindications to breastfeeding include all the following except?
UTI.
And the most effective fail-safe form of birth control is?
Vasectomy.
Correct. All right, so we'll go through these real quick. All right, so number 1 was 1 to 2 inches, and this is based on the textbook. So when I do the quizzes, I want you to read the textbook. So I base it exactly word for word from the textbook. So that's where that's coming from. But I believe I have that in one of my slides. And I'm going to,
You have it less than 1 inch for scanned.
okay. But for the textbook, it says 1 to 2. An important nursing action that allows for the identification of potential complications such as uterine atony, and that was assessing the fundus. Number 3, colostrum is the clear yellowish fluid that precedes milk production. Contraindications to breastfeeding include all the following except, and that's your UTI. And then the last one, the most effective fail-safe form of birth control is vasectomy. So that was your quiz. All right, this is what I want to focus on for tonight. So I pretty much went over with you. We're going to talk about the changes that occurred during the postpartum period. We're going to remember the changes that occurred when the woman became pregnant and all of those physiological changes. Now we're going to reshift those physiological changes back to the pre-pregnancy state. So we're going to be kind of shifting everything around to the pre-pregnancy state. We're going to talk about some critical elements for assessing and nursing care during the postpartum period, safe, effective nursing care during the postpartum period, and included in that umbrella is your contraceptives and teaching about different contraceptives, discharge teaching, and then a little bit about bonding, attachment, and the family dynamic. So that's going to be just a very small portion of that. So does this look familiar? You guys see this before? So this is what we would call a flow sheet or a Cardex back in the day. Now a lot of stuff is electronic, but it pretty much kind of covers everything that you would see and everything you'd be assessing and what you would need to know. So it kind of goes over, excuse me, it goes over the whole patient, starting from her labor, her estimated due date, diet, PP or PO is postpartum or post-op day. So postpartum is if she had a vaginal delivery, post-op is if she had a C-section. And then it goes into her estimated date of delivery, goes into if she's breastfeeding, bottle feeding. And then it like covers your section here on perineal care. Is it intact? Birth? What time was it? Was it a vaginal? Was it a C-section? If it was a vaginal, was it spontaneous? Was it assisted in some way, such as with a vacuum assistance or with the forceps? And then the C-section, was it planned? Was it an emergency? If it was an emergency, why? If it was planned, why? Right? So different things. Goes over the infant, and then it goes over immunizations. One of the newer ones, and we won't get into a whole lot about it right now, but we were talking about it earlier, is giving or pregnant women delivering who have received the COVID vaccine. So we're starting to see pregnant women in healthcare, especially, that are being given the COVID vaccine. And I was just reading, I'd like to read a little more about it to really make an educated guess and kind of see what is going to transcribe from here. But a couple of women have delivered babies, and the one was talking about a woman in Florida who delivered, and her baby has antibodies to COVID-19 from her receiving the COVID-19 vaccine. And then there's others who have seen that with the woman who was positive for COVID-19 during pregnancy. And then my next question will be breastfeeding. How does that affect the newborn? If she received the COVID vaccine during pregnancy or during breastfeeding, does that carry over to the baby? So kind of in some interesting things we can start looking at. So I'm going to spend a lot of time talking about bubble he and then add the P to it. So this is kind of encompasses your entire postpartum assessment of your mom. What would be the 3 highest complications that we would be concerned about within the first 24 to 48 hours with a postpartum mom?
Bleeding.
Bleeding, hemorrhaging, good.
Fever,
What's that?
fever,
Fever, right? So infection
What about clotting?
and blood clotting. Very good. So there are 3 big hitters. So keep an eye and keep that in the back of your mind when we're going through the assessment. So what I want you to know, and I really want you to be able to speak to this, and what I want you to know is, what exactly are you assessing? Why are you assessing it? What is normal? And how are we intervening if it's either abnormal or discomforting to the postpartum woman? So it uses this acronym called bubble he P. So I'm going to follow through this whole thing. So the first thing starts off with the breast, and you're looking to see, after a woman delivers, her breasts are going to start to fill up with, well, they're not going to fill up with milk per se initially. It'll initially be the first milk is called colostrum. And then the colostrum is going to transition over to the milk at about 3 to 5 days. Some women earlier, some women later, but just give or take ballpark. So we want to look to see, is it soft? Is it filling? Is it engorged? Is there colostrum? Generally, we won't see the breast milk because she'll be discharged at that point. Then we want to look, is she bottle feeding or is she breastfeeding? Because we're going to handle those 2 differently, right? If she's bottle feeding, we don't want to encourage the production of milk. And so we need to stop that production of milk. And we have several ways of doing that. So if she's bottle feeding, we want to make sure that she has a tight fitting bra. I generally say a size smaller than what she currently is wearing. Sports bra works pretty good. Something very tight and constrictive, not too constrictive where you can't breathe, but just something that's going to help. That's going to help decrease the milk production. One of the non-pharmacological holistic things is called cabbage leaves. I don't know if anybody's heard of cabbage leaves, but cabbage leaves is known to, you get you get that right from the grocery store. So it's exactly how it sounds. And then you put those inside the bra, and that's supposed to dry up the milk. It can be very discomforting to semi-painful at first. Ice, obviously not directly. You want to have a barrier first. So ice, some ibuprofen or anything like that, that can help. no nipple stimulation. When she takes a shower, have her turn her back to the hot water. So that would be for your bottle feeding. For your breastfeeding, you want to be, again, they're going to have a well-fitting bra. You want to assess the nipples depending on the shape of the nipple. They may need some accommodating devices. Like if they have an inverted nipple, which means the nipple it goes inward instead of outward, or very flat, they might need a nipple kind of a device to put over top of that to help both bring the nipple out and give the baby something to latch onto. You want to make sure that the baby is latching on completely around the areola and not just on the nipple. That's going to cause very cracking and sore bleeding nipples. Generally, I can tell after a day or so if the mom is very sore and her nipples are cracked, that the baby's not latching. And hopefully we catch that before a day or so. Hopefully we're doing education all along. You can have them apply lanolin cream. That's okay with the baby. Obviously, you wipe it off right before the baby nurses. And another thing, they say air dry. And I've also taught moms to take a little bit at the end of the feeding, take a little bit of the breast milk and just put that on the nipples. And it kind of serves as a natural moisturizer and to help prevent cracking and bleeding of the nipples and of the breast. So now we're going to go down to uterus. This is one of our biggies. This is one of our very important ones, and there's a lot going on here. So when the woman delivers, her uterus, or the top of the fundus, should I say, is at or maybe a finger breadth above the umbilicus. So everybody put your finger out like this. And then let's just pretend our nose is our umbilicus, right? So it might be just about a finger breadth above our nose. So here's our nose. So it might be right about there when she delivers. And then it's going to go about a finger breadth per day below. So here would be at the umbilicus 1 day, 2 days, 3 days. Does that make sense? You probably won't see anything past that because she'll be discharged. Eventually, by the time she follows up with her postpartum appointment, 5 or 6 weeks postpartum, you shouldn't even be able to feel where the top of the fundus is, because it's gonna pretty much go back into pre-pregnancy state. So you should not be able to feel it. So some things we want to look for. Did anybody do any fundal assessments on clinical? Okay, Joanna, good. So, Joanna, when you did the fundal assessment, was the fundus firm or boggy?
It was a little bit like a ball.
Okay. Did your instructor have you massage it a little bit?
Yes.
Okay,
The nurse had me massage it to see where it was.
okay. Good, very good. So you want to, when you go to assess the fundus, you want to use 2 hands. Your non-dominant hand, say your non-dominant hand, I'm just gonna say is your left. You want to kind of put that at about the symphysis pubis, because you don't want to be, especially with the massage, you don't want to be pushing really hard onto that uterus. We don't want any prolapse, right? We don't want to cause any problems. So we want to support the bottom of the uterus with our non-dominant hand, and with our dominant hand, we want to kind of try to reach and find the top of the fundus. If it's firm, if it's midline and it's not, and it's midline and at the umbilicus, we're good. If it's displaced, and it can be displaced either right or left, if it's displaced, if it is boggy, then we want to, if it's displaced, what can that mean?
That's what I was going to ask. It was a little bit shifted to her left,
Okay. So
and it was firm.
okay. So if it's shifted a little bit and it can be right or left, it usually indicates a full bladder. So
Okay.
you want to have her, you want to assist her to the bathroom and have her void. If she's unable to void, or if it's really boggy, you're having problems and you're worried, blood pressure starts dropping and we're worrying about postpartum hemorrhage, then they may, you'll have an order to straight catheter and drain that bladder, especially if she had a C-section, she had an epidural, a lot of pushing, and really is still pretty numb down there. So we want to check and see, is it firm or boggy? We want to see what is its relationship to the umbilicus. Is it at the umbilicus? Is it one finger breadth above? Is it one finger breadth below? Is it deviated? Okay, so we're going to be looking at all that. If it's boggy, but it's not deviated, then we want to massage it. Again, you want to support the base of it and massage the fundus, and because a full bladder is not going to allow that fundus to completely. That's probably why you said it felt a little bit like a ball, because the bladder being full is going to make it. It's not going to be able to contract as it should. Good. So then, since we're talking about the bladder, we'll kind of jump down to the next letter B, and the next letter B is bladder. Now you can flip flop bladder or bowels. I'm fine with either way. You want to make sure it's completely empty. When she first delivers, they want to measure the amount that she voided, because they want to make sure that she emptied her bladder completely. So you want to make sure there's no signs of any UTI, so no burning or pain upon urination. And again, measure that first void. The next B is your bowels. And not always does she move her bowels. She actually may move her bowels during labor if she has a vaginal delivery, and that is something you never want to tell her. Just a little FYI. You want to listen for bowel sounds. Tell her the bowels, everything will kind of start working with, about 24 to 48 hours. Sometimes it may be, the first day home when her bowels kind of start working again. And it could be from a variety of reasons. Medication, the whole labor process. She might have a little bit of anemia, so they're giving her iron. So it could be, not a lot of moving around in the hospital, not drinking enough. All those things could impede it. Another thing is she could have a lot of painful hemorrhoids, and that's going to make it difficult to move the bowels, or painful to move the bowels. Any questions so far on up until the last B? All right, so we're going to go over to the L for lochia. And we want to look at the lochia, and we have 3 types of lochia, or 3 colors of lochia. We have rubra, which is what?
Right?
Red? Red, very good. Cirrus, which is a pink, and then alba, which is a white or a beige. We are both most likely only going to see the rubra. By the time it starts changing over to cirrus or alba, again, she should be home. Even if the baby's in the NICU and the baby doesn't go home and she does go home, she's going to come back as a visitor. She's not going to come back to the postpartum floor. Then we want to assess her perineal pad. We're going to assess her. And the biggest thing that I really want you to remember about the perineal pad is checking for clots. And we want to be looking to see if she has a very heavy amount of lochia that saturates the pad more than an hour, within an hour, or more than an hour, or less, less than an hour. So we want to be really watching for that. Sometimes if she's laying flat for a while and then she goes and she sits up, that first time she sits up, it might just kind of gush, but we want to just kind of look at the whole picture. So is there a large amount of lochia? Is it very red? Is there large clots like the size of a lemon, or are they very, very small, like the size of marbles? So we want to look at the size of these clots. And then we want to look and see, what does her vital signs look like? What does her labs look like? So we're looking at this whole picture. The next one, we're going to look at incision, and it's going to be one of 2 things. If she had a C-section, we're going to be looking at her abdominal incision, right? And we want to look for the same things we would look for any incision. We want to look and see that it's clean, dry, and intact. We want to see no redness, no swelling, no pain, right? So we want to assess it, no drainage. if she had an episiotomy or an incision or she tore, when she turns on her side, we want to take a look. And that's a good time when she turns on her side to take a look to see if she has any hemorrhoids. Take a look at that incision. Look at the episiotomy or laceration. Again, looking to see that everything's clean. We can also take a look at the perineal pad, and change it as needed. And we can listen to her lungs. I'm also taking a look at when I'm doing my assessment. I'm kind of looking to see when after I'm done looking at her, checking for the fundus and looking at the perineum and looking at the pad. Take a look at her lower extremities. Are they bilaterally edematous, or is there one more edematous and red and warm than the other? Because we want to be where, she's at risk for clots. I think somebody said that. So take a look. Does she have edema? Are they equal, or is the right more red, swollen, painful than the left? Does her lungs sound really junky? Is she short of breath? Right? So all those things. Again, then next thing is emotional state. Does anybody know the name of the scale that we use to check to assess for postpartum depression?
Edinburgh scale.
Very good. The Edinburgh. Did anybody use that in clinical or see that in clinical? No. Okay. So the Edinburgh scale, they should be assessing her in the hospital, and they're also going to follow up on her postpartum visit. And from what I'm hearing, they're now doing it in some of the pediatrician offices as well, because they want to really make sure they capture that. So we're looking at bonding. Is she accepting the baby, or is she pushing the baby away? I mean, if she just had a 14-hour labor and then she's had the baby with her for the first, 6 hours postpartum, and she asks the nurse if the nurse can take the baby into the nursery for a couple hours so she can get a nap. Is that okay? Yeah, Joanna's saying yes. She's like, please, I need sleep. But if she's constantly asking you to take the baby to the nursery, when you bring the baby to her, she's not making eye contact. She's leaving the baby in the bassinet, maybe just picking up the baby to feed or, feed the baby. And that's about it. But really kind of looking like she's not accepting the baby. That's what you want to look out for. That's, that you want to keep an eye on that. And then the last piece of the bubble heat is your pain scale. So you always want to ask them, are they having pain? Can they rate the pain? Can they tell me where it is? And then do they want something for pain? And then we want to reassess it 1 hour later. Look to see what did they have last. So you want to be monitoring their pain as well. So that's a kind of a big umbrella, kind of covers everything we're going to be talking about. But I would make sure you can speak to this, make sure you know this when you're going to study for your exam. I'm not going to play these two videos, but you have the links to the videos. They're both really good. When you're studying your postpartum stuff, I would highly recommend pulling up the video. I want to say the postpartum assessment is, what's it, like 48 minutes or 38 minutes, something like that. And then the placenta examination is a few minutes. So I just want to show you, because they've changed it since I posted it before, and they put some disclaimers there. So if I go to watch it, this is going to come up. It's going to say that the video is inappropriate for some users. Yeah, if you're under 18 and it's going to show, the breast, it's going to show the vagina, is going to show assessment. So yes, I can understand that. So you just have to click on here where it says, I understand and wish to proceed. And then
we're going to examine the placenta.
That one's for the placenta. And then the other one is the postpartum assessment. 29 minutes. So you just have to bypass that. It'll let you go through, but you just have to bypass that. All right, next thing we're going to talk about is what are some normal findings? How is mom adapting to her new postpartum state? So we're going to take a look at the vital signs. Her pressure and her pulse should be returning more to normal. Her pulse may be a little bit lower than in labor. Again, the uterine fundus, we talked about that. In a normal finding, it should be midline. It should be at the umbilicus or 1 finger breadth below, and it should be firm. Lochia at this point would be rubra. We'll start seeing it turning to to a pink and to an alba after the fact, so we won't see that part. The lochia should be small to moderate. If she does pass clots, they should be small, not big, huge lemon size clots. Her bladder should not be palpated. The only way her bladder would be palpated is if it was full. Her perineum should be smooth, pink, and without bruising. And her emotional state may be kind of, all over the place, but in a good way. She's happy she had this baby. She's exhausted because she had this baby. She's crying because she, and we cry tears of happiness and we cry tears of sadness. She may be crying tears of happiness because she's been trying to have this baby for a really long time. She's been trying to have a boy or trying to have a girl for a very long time. And she could cry tears of sadness for other reasons, right? So there could be a variety of emotions. As long as you're not seeing where she's just kind of shutting down to you, to anyone who's visiting, to her significant other, and especially to the baby. That's what we want to be looking for. So this shows you assessing the fundus. Now you see this one is deviated to the right. Can you guys see that? So it's where it's, if you look at it's here is your umbilicus and the fundus are showing you the line all the way over here to the right. And then as you see, the bladder is full. So have her void and then massage that fundus and reassess. So here is how you're measuring those finger breaths. Remember I was showing you with my nose? We were going like this. My nose was the umbilicus. So in this diagram, the fundus is at B, and B is your umbilicus, right? And then you see the line above the B? That's where it can be, she may deliver and it may go up 1 finger breadth above. That's okay when she first delivers. And then after about 6 to 10 hours after she delivers, it'll start going down 1 finger breadth. And the golden rule is about 1 finger breadth per day. So 1 here, 2 here, 3 here, and so on. Okay. So how many days postpartum would you say she's at letter A? 5. I saw Ashley, I read lips well. Matt saying 5. Very good. So she's at 5. Any questions with any of that was as far as assessing the fundus, assessing the it's actually called involution. When the fundus starts to go back to pre-pregnancy state, it's called involution. Any questions on that? Everybody good? All right, so I talked about involution. Now, some of these slides I'm going to go through kind of quickly because I kind of ramble on a little bit and I kind of say things that are ahead. So I'm just going to take a look here. We talked about the first 2 bullet points. The risk of hemorrhage is the greatest within the first 24 hours of delivery. So vital signs, we're going to be taking her, and this is just a traditional vaginal delivery, we're going to be taking her vital signs every 15 minutes times 4, then every 30 minutes times 2, then every 4 hours for the next 24 hours, and then it may go to once a shift. But and that is dependent on if she's, as long as everything's going well. If she's on magnesium, then it's going to be every 2 hours. So there's going to be different reasons, but normally that's the pattern that we follow. But like I said, the biggest risk of hemorrhage is that first 24 hours. All right, let me see. I think I pretty much talked about this. I talked about how to assess the fundus. So remember, we put one hand, and I generally take my non-dominant hand at the lower segment of the uterus, and then use the other hand, the side of the hand, and then I'm going to palpate the abdomen until you locate the fundus. It's not as easy as it seems, is it? A lot of reasons. Some are harder to find than others, depending on the anatomy. If she had a C-section, it's a little more difficult to be pressing on the woman. So not everyone is easy to find. And then a firm fundus is a good fundus. It means that the uterine muscles are contracting, and then bleeding should not occur. We talked about measuring it, finger breaths. Fundal height gives you the information again about how much it's going back into its pre-pregnancy state. And then we talked about assessing lochia. Any questions on assessing the fundus? Okay. Perineum, we talked about that. One of the things I want to talk about is inspecting for edema and hematoma formation. And with the hematoma formation, that is a risk factor for postpartum hemorrhage. And it's postpartum hemorrhage related to the hematoma, because the hematoma, depending on how big the hematoma may be, is containing blood, right? So it's blood that is being taken away. It's being absorbed. So we want to be monitored. If she complains of an excessive amount of pain, you want to really assess that. And the only treatment for that hematoma is it needs to be surgically. The physician will need to aspirate, and so she'll need to go into the OR. Whether she's fully anesthetized or not is depending on what's going on, and depending on if there's other issues going on. But it does need to be treated. Ice packs, if she had lacerations or episiotomy, ice for the first 24 hours. Remember your first aid, right? Ice and then heat. So ice for the first 24 hours to reduce the swelling, and then she can have heat pads or losing my train of thought. Sitz bath. I'm sitting there like where you sit in the little, the sitz baths remind me of the bidets, like in the toilets, except they're warm versus the bidets are probably a little cooler. Assess the episiotomy. Have her turn on her side. You might have her lift up her anterior buttocks a little bit so you can assess it, and just let her know it takes about 2 to 3 weeks for that episiotomy to heal. We can give her, she can have sitz baths, like I said, after she's done with the ice, some ointment, some pain medication, ibuprofen. Lochia, basically the lochia is all of the afterbirth ridding itself from the body. So initially it's very, very red, 2 to 3 days. It's rubra. Small clots are common. By the time she's getting ready to go home, it's transitioning over to your serosa, which is like a pink color, and then it'll turn to a lochia alba, which is your white or a beige color. Breastfeeding may increase the initial lochia especially when the milk is letting down. It'll also be contracting the uterus, so she might get a lot of after pains, which I'm going to talk about. One of the things that I always mention to my moms is it's reversing. So say it's kind of going lochia rubra to lochia serosa, and it's having very small to minimal to no clots. And then all of a sudden it goes back to rubra and it gets heavier again. that's a concern. And that could indicate postpartum hemorrhage. And I want to be starting to, do all my assessments and look and see, do I need to intervene? If she's starting to have postpartum hemorrhage, what medication would you expect to be giving?
Oxytocin.
Right, oxytocin. And then we could also give an injection. There's other medications we could give. Anybody know of any other medications we could give?
Cytotec.
Cytotec, methergine, Hermapate, right? All right, and then here is, and this is from your textbook again, your different pads. And what I'm really concerned about is that heavy amount. Is she saturating that peri pad within an hour? That's a big concern for me. And so it should be for you as well, right? We're like, all right, something's not right here. So what should we report? Hypotension, tachycardia, uterine atony, excessive bleeding. All those 4 things are telling me that I'm looking at a possible postpartum hemorrhage. Temperature over 100. Generally, it's like 100.4 is where we start to kind of worry. Initially, a slight rise in temperature is normal / not normal. It's normal for the postpartum. Did anybody take vital signs postpartumly for any women in the clinical unit? Oh, Joanna, good. Do you remember what her temperature was initially? Was it slightly elevated?
Yes, she was sweating a lot. She had been in labor for a day and a half. It was her first baby, so 21-year-old lady.
Mm-hmm.
Her temp was initially 99.9,
Mm-hmm.
and then it came down, like talking to her, giving her some water to sip back and forth. After labor, it was like 100,
Yeah.
and then it started coming down.
Yeah. And that's okay. So you'll see that, Joanna, you'll see that kind of go up because of all that's going on. And don't forget, dehydration. Think about in your older adults, dehydration is going to raise your temperature, right? So do you think she's dehydrated? Oh, heck yeah. Right? Absolutely. All we were giving her is ice chips throughout that labor. So absolutely. So these, but anything like 100.4, we really start getting concerned, or we're watching it at 100. We're like, okay, but we're looking at that whole picture. And from what you were telling me, your nurse was probably like, okay, I know it's elevated, but let's just kind of keep an eye and see, are there other things going on as well?
Yeah, that's what she said. And then she gave her Motrin, and then it started coming down. It was
Good.
like 98.7.
Good.
Professor, what would hypothermia indicate? Like if instead of the temperature going up, if it goes to like down too much?
That could be from medications, especially some of your narcotics. It can cause that, and anesthesia can do that. And also, some women get the chills and they get extremely cold after delivering from all the fluid shifts and stuff like that. And so some women will get really warm, like Joanne was talking about, where she was very sweaty and hot. And others, depending on the medications and how their body reacts and stuff like that, or C-section, as because they keep it cooler in there. So it could be a lot of different reasons. So you can see it going either way. And then a lot of times if they get real cool, they have nice heated blankets that they could give them and kind of bundle them up and warm them up, especially postpartumly. Good question. Good point. All right. I think most of this stuff I covered. I want to just kind of revisit when the milk comes in. So the milk comes in about 3 to 5 days. And prior to that, they have colostrum. And even if mom doesn't want to breastfeed the whole time, even if she just wants to at least get the colostrum into the baby, the colostrum is so rich with immunoglobulins. It has really good protective properties. and the milk is designed perfectly for that baby. If a woman delivers a 5-pound baby and the baby's in the NICU, that body knows to make just the perfect milk for that baby. If that baby's larger, that body knows to. It's like we're like a magic machine like that. So even if they don't want to continue to breastfeed, if you can encourage them at least for the first, couple of weeks, anything is better than nothing. I'll talk a little bit more about that, but I always say we are a no judging zone. I have worked with nurses that are very judgy about a woman not breastfeeding and will make them feel very terrible about their choice, not investigating why they chose that. And is it for us to know? Sometimes no. Sometimes they'll freely share. Other times it's none of our business, and we have to just respect that. So this kind of shows you the changes. I'm going to be absolutely honest with you. I have never seen pink milk except my quick, when I take the quick powder and put it in my milk. That's when I've seen pink milk. I have never seen now I had a nice discussion with my Morgan group yesterday, and they have radishes. I mean, maybe they ate an excessive amount of radishes. I'm not quite sure. So I have not seen that. Blood in the milk ducts can make it rusty color. So if you look over onto your right side where you see it a little bit rusty, that could be, or certain medications. So let's talk about numbers 1 through 3. 1 is what it looks like as colostrum. You're gonna say it's only a little bit. Well, what do you think the baby's belly looks like? How much do you think their stomach is? Wee little stomach, right? So we have a wee little stomach. We only have to give them a wee little bit. As they get a bigger stomach, they get more milk, right? So now you go from number 1, which is your colostrum, which is a yellowish, orangish color. And then you go to your transitional milk, which goes from the yellow to the white. And then you have your mature milk. In about a week or so, you'll have that mature milk come in. And the mature milk has 2 types of milk. It has a fore milk and it has a hind milk. And I'll know a lot of times that the baby didn't get the hind milk because the mom is complaining she's nursing every hour. She goes, this baby is nursing every single hour and is never satisfied, is never full. Why do you think that is? What do you think the hind milk has that the fore milk does not? What would make them fuller? What would make you fuller? A salad?
Protein.
Protein. Your protein, it's higher in protein, it's higher in calories, it's higher in fat. So if I gave you a salad with some strawberries, or I gave you a Wawa sub with a bag of chips and 2 cookies and a glass of milk, obviously you're going to get more full from the food from Wawa, right? Versus the salad with strawberries. So kind of looking at it that way. Oh, I know what else I want to tell you. How do we make sure that baby gets that hind milk? So mom has baby all snuggled up. And what happens when you put these babies in these nice little snugglies and wrap them in blankets and hold them nice and tight? What do?
Fall asleep.
They fall asleep, right? Which is good. But do we want them to fall asleep when they're trying to eat? No. So what I tell moms is it's not cruel, and we're not trying to create hypothermia on these babies, but kind of loosen the clothing. They're still having skin to skin, so they're still benefiting, but kind of loosen it up, kind of get some air flowing, kind of wake them up a little bit, and have them nurse about 10 to 15 minutes on each side. And the fore milk is going to come out right away, but then they have to work a little bit more to get that high milk. So that's just, if mom is complaining that she's feeding every single hour, she's getting really sore, she's tired and cranky, maybe see if the baby is falling asleep too quickly. Your textbook, I'm not going to read this whole thing, but it's on page 374, box 12.3, and it goes over a lot of common findings and some breast care and assessment. So I would go back and kind of revisit. It kind of goes over a lot of the stuff we talked about, but it's just a really nice chart that really goes over a lot of information for you. And again, we're assessing for engorgement. We don't want it to be really hard, especially if she's breastfeeding and painful, because then she can get clogged milk ducts, which can lead to mastitis, and we don't want that to happen. So you want to just make sure that if the baby doesn't nurse all the way, she can express that, pump that, and again, assess for clogged or plugged milk ducts. And signs of a plugged milk duct, the breast would be very hard. It's usually unilateral, one side or the other. You usually don't see both getting, and it's usually the side that the baby's kind of falling asleep on more often. So we also tell them to rotate. I'll tell a mom to like put like a safety pin on her bra strap on that last side that she fed on. So if she fed the baby, the last side was on the right, I would say put like some kind of a clip or something on the right, so that when she feeds the next time, she starts on the right, because then that'll drain the breast more. Does that make sense? Breast care for non-lactating, I think I kind of talked about when we talked about the bubble heat. Supportive bra, avoid stimulation, cold compresses, cabbage leaves, analgesics, no nipple stimulation. I think I pretty much went over that when we talked about it in our bubble heat. So some of the stuff I'm going to be going through, I might just kind of like highlight on it if you don't mind, because I kind of readdress it. If you have a question, just pause and just have me, just ask me or write it down and we'll go back to it. This talks about reasons why a woman would not breastfeed. And there's a lot of them. So one could be breast augmentation, and it could be either a breast reduction or getting implants done, right? If they're going in and they're manipulating the milk ducts and going around, that's going to make it very difficult. Breast cancer, if they do a total mastectomy. Sometimes you might not know. Maybe the woman had breast cancer. She's a breast cancer survivor, and she had breast cancer really young. And then she had children, and she had a really good surgeon, really good plastic surgeon. You might not even know. And maybe she doesn't even want, again, that could be where she doesn't want to talk about it. Medical conditions such as HIV, taking medications, chemotherapy, antipsychotics, seizure medications, because they can go through the milk and to the baby. If she's using any illegal or illicit drugs, such as marijuana, cocaine, drinking alcohol, or even smoking, that can be passed through. And also smoking increases the risk of SIDS. And we'll talk about that in about 2 weeks when we talk about newborn care. We'll kind of go through your systems. Remember her systems now, before she had an increase in her blood volume. Now after delivery, anywhere from 200 to 500 milliliters of blood loss. And they're measuring that, they're watching that, but it increases her risk for orthostatic hypotension. She may get anemia, which will, is normal. It's a transient anemia from this normal blood loss from having the baby. So she may be on iron going home, and we're kind of watching it. Some women might have to have blood transfusions. White blood cells may increase. It, generally about 25, but it can go as high as 30,000. So just know that that's normal postpartumly, because in a non-postpartum and a regular med-surg person, if you saw their white blood cells up to 30,000, you would think that they have some kind of infection going on, right? But with the postpartum mom, it's normal, and then it starts to kind of go back in about a week. Risk for blood clots is increased because of the increased circulation of the clotting factors during pregnancy, and life-threatening pulmonary emboli. The problem with this is really educating the mom. I've personally and professionally have known women who have gone home after having a baby and had leg pain, had problems, went to sleep, and threw a fatal clot. So really educating them about calf pain, leg pain, swelling, redness, anything like that, and really making sure that you let them know these are really important things that you need to let someone know immediately. We went over the vital signs. Everybody okay with that? So every 15 minutes times the first hour, every 30 minutes, second hour, every 4 hours, the next 22 hours, and then every shift after that. And that's normal. If there's anything going on, obviously we're going to be doing it a little bit different. She should be afebrile. Again, like I said, that first 24 hours, she may spike up to about 100, 102, 100.2, I mean, due to exertion and dehydration. We will generally see a transient rise and then a decrease and return the baseline for her blood pressure. So just watch and tell her to get out of bed slowly. That first time, somebody or somebody's should be there with her when she first gets up out of bed for the first time. Respiratory, you want to have good assessment skills when you're listening to her lungs. A lot of times people kind of go quickly through there, but remember a couple of things we're concerned about is clotting, throwing a PE, and did she have a lot of fluids during labor? Did she have any tocolytics, which are actually antidiuretics? So she might, such as magnesium. So she might be retaining a lot of fluid, and we might hear some crackles in her lungs. Blood values, just monitor those coagulation values, watch for any signs of clotting. And she's going to have a set of labs done postpartumly. They want to look and compare. Hopefully they did a set when she first came in, or a baseline, and they're going to compare. I put this here just to kind of remind you, refresh you of normal PT and INR times. Some moms might have to get Lovenox or heparin. Others might have to go on a heparin drip if they suspect there's a clot. They send her down and they do a scan and see a clot. They may put her on heparin. It's not not unusual to see that she would be staying a little bit longer. She may go to the med surg floor, or if they have no room, but she's otherwise they're just monitoring her medically. I did have a discrepancy, so use these numbers here if you want to write those down. Use those numbers. I think my lab sheet said 12.5. I wouldn't necessarily be asking you what are the exact numbers. I may be asking you, here's the numbers, what do they indicate? Here's the numbers, what should we do? That sort of thing. Let's kind of talk a little bit about rubella and RhoGAM. So remember, when you're taking your test, how many are fast test takers? Going right through it, right? Slow down, because you might see R for rubella and it might be R for RH, and you're like, rubella, okay, they don't get that until after they deliver, when the question could be asking you about her RH status. So just kind of slow down. Rubella, they can, if the woman is not immune to rubella, can she have her rubella, or which is your MMR, can she have that during pregnancy? No, Ashley's saying absolutely not, right? Because it can cause serious malformations to the baby, right? It passes through to the baby. However, we want to give that to her as close to postpartum before going home, because we want to make sure we capture that. But make sure you educate her not to get pregnant for 1 month following that. Some people are gonna be like, you kidding me? I'm not getting pregnant ever again, right? So some of them might be like, don't worry, that isn't going to happen. Well, things happen. And then your RH, if she is RH negative, she's already has received her RhoGAM at 28 weeks, right? When is she going to get her next dose if the baby's RH positive?
72 hours.
72 hours. Very good. Very good. Urinary system. So we want to just be making sure that she's completely emptying that bladder, making sure there's no signs of any UTI or hematuria. Anesthesia medications and stuff like that sometimes can slow things down. So we just want to make sure that her bladder's emptying, make sure that it's not, it's not deviated, when we're doing our assessments. GI tract, it generally, the hunger generally returns pretty much postpartumly. So it's not long after she delivers that she's hungry and wants food, especially if she's had a long labor. Like Joanna was telling me, her patient had a very long labor. So once everything's all said and done, they get her all cleaned up and she's back in her, and she's on the mother baby unit. They generally want to eat. They're also very thirsty, especially if they're breastfeeding. Breastfeeding makes you really thirsty. So you want to make sure they have lots to drink. Plus, they need to replenish everything they've lost. Bowels may be real sluggish, a little slow to return. They may not move their bowels until a day or so after they get home. Anything past that, I'm a little concerned. They should be calling and getting some kind of stool softeners. Especially if they had hemorrhoids, if they had a C-section, all these different things. We don't want them straining and pushing, right? So teach all and if they're on iron, so now we're like really compounding them. We gave them pain medication. They had an epidural. They have hemorrhoids. They're on iron. Like we're just setting them up for failure, aren't we? The poor things. So you want to, high fiber, have them ambulate, lots of fluids, those kinds of things. Any questions so far? After pains are those pains that the uterus is contracting and going back into its pre-pregnancy state. It's worse for women who have had multiple children than for the woman who had her first child. And it's also very painful when she's breastfeeding and when that milk lets down. It gets, so that's releasing oxytocin when the baby's nursing. So many ways we can treat it. If she's having a lot of trouble with nursing, maybe give her ibuprofen or some Tylenol prior, like 1 hour prior to feeding or prior to assessing. Could you picture somebody coming in and you're having a lot of after pains and they come and start pressing on your abdomen and feeling for your fundus? It's not going to feel too hot, right? So maybe, you're going to go in at 10 o'clock and you're going to assess them, go in about 9:30 and say, I'm going to be in about an hour. I'm going to be, checking everything. Do you want anything for pain? Follow-up care, 4 to 6 weeks, they're going back for their postpartum appointment. They're going to be screening again in the postpartum appointment for that depression. And from what I'm hearing from some of my pediatric office nurses, they're doing that in the office as well. We're going to talk about birth spacing, reproductive plans. Some women might actually start their contraceptive planning postpartumly in the hospital. They may choose to have a tubal ligation. Some women, like one of the medications, one of the contraceptives that are safe during breastfeeding is a depot shot. They may get that first depot shot while they're still in the hospital. So, it isn't unusual. I've had women have some of those things in the mother baby unit, and then follow up on vaccines. And then just to reiterate, these are things that we want to make sure that they know: bleeding, temperature, burning on urination. And I'm going to jump down to the last one: leg pain, swelling, chest pain, shortness of breath. I want to add one more. I want to add signs of preeclampsia, because preeclampsia can occur in the postpartum period. And this is another thing that increases the mortality rate of our postpartum moms, because a lot of people think preeclampsia happens during pregnancy and afterwards I'm kind of off the hook. So you just want to reiterate any signs of headache, blurred vision, epigastric pain, fluid retention, or anything like that. Let someone know immediately. So there's some of the things that you want to make sure that you really drive home with that. All right.
Professor, actually, my patient this past week, she was discharged and came back.
All right, you guys ready? We're going to continue with talking about contraception. So this is part of our postpartum teaching. It may be done most likely in the office when they return. So we have different methods of contraception. So we have natural methods, barrier methods, hormonal, long-acting reversible contraceptives, and sterilization. So anybody want to tell me what they think natural methods are? Or an example of one?
Like abstinence.
Yep. Which has a, what type of failure rate do you think abstinence has?
0.
0. Very good. All right. What about a barrier method? What would be an example of a barrier method?
Sponge or a condom?
Right. Hormonal. Ashley's going the pill, right? Long-acting reversible contraceptives.
IUD.
And then sterilization.
Vasectomy.
Very good. When you are studying, just look back at the failure rates. As we said, the abstinence is 0, and we're going to talk about a couple other failure rates as we go through. So for natural, we have also natural family planning. Natural family planning could be doing the basal body temperature method. A little bit, it takes some discipline to do. They're taking their temperature every single day. They're charting that. So it takes, and it, if you can use it as a birth control, or it's also used for infertility. So they're looking to see when are they ovulating is really what the key is. And when that body temperature raises usually about 0.4, 0.5, and you'll see that trending. I have a diagram a little bit later, and you'll see that trending, and that's when they know they're ovulating. But there's a lot that goes into that. The next one is coitus interruptus, which is basically the withdrawal method, which we all know anatomy, right? We all know that does not work because there's semen at the tip of the penis before insertion. So we know that those little boogers can, if there's a will, there's a way. So sometimes when I work with adolescents and teens, and they say, oh no, they pulled out, I'm not going to get pregnant. I'm like, oh, okay, let's have this little conversation here. Next one is lactational amenorrhea. And lactational amenorrhea is when a woman is breastfeeding, she generally doesn't get her menstrual period, but that does not mean that she cannot get pregnant. So that's one we have to watch. So here's that diagram of that natural family planning using the basal body temperature method. And you also have to take a look at somebody's background, culture, religious beliefs. Some people, they do not believe in any birth control, so they have to use different methods that are permissible. Barrier, we talked about the different barrier methods. The one that provides that protection against the sexually transmitted diseases is your condoms, right? Other ones are your sponges, caps, diaphragms, gels, creams. And if they're in a strictly monogamous relationship, and they've been in that strictly monogamous relationship, and they have no desire to be with any other partners, and they've been with no other partners, then some of the, using other methods will be fine for them. If they, and that's not, again, not for us to ask, but if they're having multiple partners and there's that risk of infection, then condoms in addition to something else. You just always have to say, let them know that this does not provide any protection against STIs, which I'm still used to calling STDs, but the new terminology, STIs. There's a picture of a condom, just in case you don't know. Now you know. And one of the other things you need to let them know, condoms break, and they need a new condom for each encounter. So it's not a one time for every encounter, because they're going to break and it's not going to be effective. Vaginal sponges are placed in and up against the cervix in there to and a lot of times they have some spermicide in them to not allow the sperm to impregnate the woman. Cervical caps, and if you want to highlight this with your cervical caps, they need to have a provider fit them. They're not a one size fits all. So, and also something that you might want to keep in mind, after they deliver a baby, or they may change sizes, they lose a lot of weight or gain a lot of weight on either end. With the cervical caps, one of the drawbacks is they have to be left in place for 6 hours. So that might be something that some women might not be comfortable with, and that might not be a good option for them. And it also doesn't provide any protection against your sexually transmitted infections. Diaphragm also needs to be fitted by the healthcare provider. And it's not recommended for women with any UTI or history of UTIs, yeast infections, and it increases the risk for toxic shock syndrome. And this also needs to be left in place for 6 hours. So again, one of the biggest things that you want to ask is what works best for them, because we want what works best for them, because then they're going to be compliant, right? Spermicides available over the counter, usually used with another barrier method to increase the effectiveness. And again, not effective against STIs. Your hormones, I remember Ashley was going like this for the pill, right? So your pill, and it can come in many forms. Pill is one form, injectables, implants. We're going to talk about all these. It can be combination of estrogen and progesterone, or it could be progesterone only. So if they're breastfeeding, what do you think their option is?
Progesterone only.
Right, progesterone only, because the estrogen can affect the milk production. So you have the combinations. The combinations have a low failure rate. This combination of your estrogen progesterone is 9%. The big takeaway, other than it doesn't provide any protection against your STIs, the big takeaway, I would highlight that and revisit that, is the contraindications. These estrogen, progesterone, or combined, they're called, the combined oral contraceptives, increase a woman's risk of having a stroke. So if a woman has a history of stroke in the family, she gets up in age, 35 is kind of the age where she's more likely to be going through perimenopause, having issues with clotting disorders, smoker, history of hypertension, high cholesterol, and estrogen type of estrogen feeding cancers, like your reproductive cancers, breast cancer, ovarian cancer. All those are contraindications for this combination of the estrogen and progesterone. Any questions on that so far? Emergency Plan B, you learned about that when we had Amanda Howitt's presentation. They'll use that if a woman comes into the emergency room for sexual assault, and that's in a menagerie of other medications as well. It's not a regular form of contraception, and it should be taken within 72 to 120 hours of the incidence. And it could be possible contraception failure, broken condoms, slipped diaphragm, missed contraceptives. And again, it's not a normal regular form, but I do talk about that.
Professor, are there any contraindications with the with that one pill? Because it's only a one-time dose, isn't it?
Yes. They didn't say anything as far as any contraindications with it. I can definitely take a peek, but I didn't see anything in the literature because I always kind of revisit these. But I'm just going to put myself a note here. If there's any if there is, I'll just at a break or something, I'll look it up and then I'll let you know. Okay. The progesterone only, and you want to highlight that this is you'll hear this being called a mini pill, the progesterone only, and they can use this during lactation. It's a daily, every day. Don't get hung up on when they need to be given, or when, like, need to take it at, day 1 of their menstruation cycle, day 5 of their menstruation cycle for 1 week. I'm not going to ask you those type of questions. So don't try to drive yourself crazy trying to memorize that. I'll tell you, what I want you to know about the contraception is pretty much on my slides, except for looking at the failure rates and stuff like that. These do have a higher rate of a failure rate versus the combination because they don't have that estrogen component to it. But again, they can be used during lactation, and these are good options if they have contraindications to using the combination. Does that make sense? So Depo-Provera, I'm sure a lot of people are familiar with the Depo shot. That is a progesterone only. It can be given, used during lactation, and that's in every 3 months. So they do have to come into the physician's office and have that. That's not something that they can take home. They do have to make an appointment, and they come in and they get their Depo shot. And that's given IM. Your topical patches. So a couple of things I want you to know about the patches is think about how is that being delivered? What's the delivery? It's being delivered and absorbed through the skin, right? So keep that in mind with what I want to tell you. So it's being absorbed through the skin. So we want to make sure the skin's clean, dry. You're going to apply a patch. A new patch is applied the same day of the week, every week for 3 weeks. And then the 4th week, no patch. You can rotate sites. But the thing with the patch, the way it's absorbed is it's absorbed through the subcutaneous tissue. So if a woman is larger, has a higher BMI, or weighs more than 198 pounds, it's not going to be as effective because of how it has to go through the subcutaneous tissue. So you might look at other options, but just keep that in mind because we don't want them to think it's effective and find out they're pregnant, right? They're taking this because they want to prevent a pregnancy. So we want to help them. And side effects, weight gain, mood changes. And anytime you put anything on the skin, you risk that irritation at the site. A vaginal ring, it's a hormone-filled ring that's inserted and left in for 3 weeks, then removed for 1 week, and then a new one. Or they actually, that last week, it's basically a placebo effect. So if they're very forgetful and they want to, okay, I don't want to make sure I want to forget this, they can put it in, and it can be left in place for 28 days, taken out, and then replaced with a new one. So whatever works. It just really depends on, what works for that woman. And this kind of goes back to the combinations. I should have added this after the combination. This is a all-inclusive list, so it's a lot more than what I told you before. Obviously, pregnancy, If they're pregnant, that's a contraindication to taking contraceptives. It's not going to really do anything, and it can only cause harm depending on what they're taking. Any history of clotting disorders, blood clots, history of strokes, smoking, high blood pressure, hyperlipidemia, diabetes, any estrogen dependent carcinomas, and gallbladder and liver disease because of the hormone issues and the relation to clotting and stuff. So that just kind of gives you a broader spectrum. Any questions on that? So your long-acting reversibles, they are reversible upon discontinuation. They're very suitable for adolescents because they can be long-term, and they're cost-effective, and it's good for those who are non-compliant. Your long-acting injectable progesterone only. Again, don't get concerned about when that dose is given. I'm not really going to be having you, I'm not going to be asking you, when is that being given? Side effects, amenorrhea. So the trouble with that is let them know that if they do plan to get pregnant, they may have to, once they stop it, it may take a little while for the menstrual cycle to get back into a normal rhythm. Your intrauterine contraception, it's inserted in the office or in the postpartum. Did anybody have any women who had this done postpartumly that you know of? No. Okay. It can be used with lactation. Good 1 to 10 years. Honestly, that makes me nervous. Something in there for 10 years just, makes me nervous. The copper IUC can be used as an emergency contraceptive as well, like the Plan B. And look at the failure rate here. We're at 0.2. Well, we're at 9 before, right? 0 for abstinence, 0.2 for the IUDs, IUCs, and then 9 for the combos. This is blown up so that you can see what it looks like. So don't freak out like, oh my gosh. So that's what it looks like on a large scale, just so you can see. The implants are subdermal. So as far as I know, there's not an issue with the weight because they're subdermal and not in this, directly on the skin. So a rod is implanted. It's an office procedure, lasts for several years, and this also can be used during lactation. All right. So what I'm going to do, I'm going to pause here with this. I'm just going to.
Several years. She's frightened of injections and her husband does not like to use condoms. She has heard that COCs are easy to use and effective. She'd like to give them a try. You conduct some basic screening and obtain the following information. Her blood pressure is 140/90. She was diagnosed with tuberculosis 8 months ago. She smokes 6 to 8 cigarettes a day. You observe mild varicosities on both lower legs.
Excellent. Claire, you want to read question number 1, and then Claire's group can jump in.
What other information do you need to obtain in order to assess whether COCs are the best choice for her?
All right. So Claire and group, what did you guys come up with?
We said like the compliance of her taking medications every day.
Good. Did you guys have anything else?
Did more than one group do case study too?
Oh, yeah. Yes.
Oh, okay.
Oh, you mean other than case study 2?
Yeah, because Markella and I we did the same case study too as what we're doing right now.
Yeah, that's what we're going over. Yeah.
Oh, sorry. Maybe I didn't hear. Sorry.
That's okay. Anybody have any other information? Hold on, my little dog's coming in. All right, you can stay in here, little dog. Any other information? I'll show you the little dog. This is my little dog.
Our group put so compliance with if she's going to take it or not, maybe like lipid levels, liver testing, and if she has a history of cancers.
Excellent, excellent. Anything else?
Our group put like clotting disorders.
Good.
We want to look at her weight because if she doesn't want to be compliant with pills, then the patch wouldn't be good for her.
Good, good. Okay, so some other things I had. Well, obviously we want to check it to do a pregnancy test because it didn't say if she was pregnant. So we want to check that, or is she breastfeeding? And it didn't say it in the story, so I don't know. So and then I had BMI, which you alluded to, Thomas. She was diagnosed with tuberculosis, so I want to know what medication she's on, because to see if there's any contraindications with her medications, coagulation studies, like you guys said, family history, do a lipid panel. You guys said that already. And, ask her about her plans for smoking cessation. Maybe, at least try to eliminate something off her list if we could. Let's see. Aldonza, yep, you're there. Do you want to read question number 2, or do you have it handy?
Yeah. The rest of the client's history and assessment do not reveal any precautions for the COCUs. Are COCs an appropriate choice for this client? Why or why not?
And then I know you were jumping in and out. Just listening to that, do you want to give an educated guess on her background? What do you think?
I'm kind of trying to read and trying to catch up on it.
Oh, that's okay. Okay, so some of the things that stood out. She's 31. Her blood pressure is 140/90. She was diagnosed with tuberculosis 8 months ago. She smokes 6 to 8 cigarettes a day, and you observed varicosities on both of her lower legs. So does it sound like she's a good candidate for combination? No.
No.
Let's see. Minar, you want to read number 3 for me, please?
If she does use COCs, what counseling and information does she need?
Okay.
Smoke cessation program, maybe losing weight if she has a high BMI. Consult with the cardiovascular doctor to see if she has any, because she has varicosis, if she has any thrombosis or deep vein thrombosis.
Good, good. Did anybody have anything else? And then let's see. Amanda, do you want to read number 4, please?
If COCs are not an appropriate choice, what other methods might be?
So what did your group come up with?
We said IUDs.
Yeah, because she doesn't want anything that injects, right? If we determine her BMI, like Thomas was saying, if we determine that and she was within a normal range, the topicals might not be bad. Did anybody have any other choices for her?
Vasectomy.
Yeah, for the husband, right?
We got 5 kids. Like, let's stop it.
But she's not sure, right? And then maybe like that ring, right? The vaginal ring might be inappropriate. Oh, another thing that I would also look at would be, does she go to have routine pap? Has she had routine pap smears done? And what are her menstrual cycles like? Are they regular? And there were some of the other ones. All right, very good, very good. All right, let me pull back my screen here.
Professor, are you going to give us the answers?
I did. That's what I was,
Oh.
what we were just going over. Anything additional I added.
Okay, thank you.
You're welcome. All right, so the next thing we're going to talk about is operative sterilization. And for the man, it's vasectomy. And it's severing the vas deferens on both sides of the scrotum. So it's basically surgically severing that pathway, or what some people call is the snip snip. I don't know if anybody's ever heard of that. And it can be reversed, doesn't guarantee pregnancy. And it also can spontaneously re-anastomose. What does that mean?
It grows like reconnect or like grows back kind of.
Right, right. So you have to really make sure they follow up with all the follow-up appointments, and, you know, make sure that they have their sperm count analyzed afterwards are some key things. We're going to talk a little bit, because I'm going to give you another little activity in a minute, so I'm not going to go into a lot of detail yet. And then for the woman, they can have a tubal, or they can do a sterilization implant, which is in the office. The tubal is a surgical procedure under general anesthesia. So sometimes they may make that decision right after delivery, and they may have, if it's a vaginal delivery, they'll have that like the next day. A C-section, they might be able to do that right there. So that would be, but it's more invasive for the woman to have the procedure done than the man to have the procedure done. So it is less risky, but it's just really, it really depends. And I'm not going to go into a lot, because I'm going to give you guys another little activity. All right. So if you want to write down what you need to do for this activity, I have it here on my screen. So when I put you in groups, I want someone to pull up the ATI Active Learning Template Therapeutic Procedure. So that's a template you're going to pull up. And then when you have that pulled up, you're going to do only 3 things, because there's a lot on those, right? On some of those active templates. It's like some of them are like, you know, 8, 9, and 10 blocks to fill out. I'm having you do 3. So we're going to keep it short, sweet, and simple. What I want you to do on the template, the first thing is in the description box, I want you to describe what a vasectomy is. So we're going to be focusing your ATI template on a vasectomy. So the first block, and then one person can be the writer and the others can be sharing, or you can all write, doesn't matter. And then the next thing I want you to do for indication, I want you to write 1 advantage and 1 disadvantage to having a vasectomy. And then the third thing is client education. So I want you to describe 2 teaching points for the vasectomy, like 2 teaching points that you would give a patient who had a vasectomy. So just again, just to summarize, I'm going to put you in groups. I'm going to give you different groups so you can have new friends. Give you new friends this time. And then you're going to get the therapeutic procedure. And then I want you to do the description of a vasectomy, indication for it, 1 advantage, 1 disadvantage, and then client education. And you're going to describe 2 teaching points. So I'm going to stop sharing. And everybody coming back? Oh, Aldonza, you're muted. All right, who didn't I pick on yet? Who are we missing? Is there still people in the breakout rooms? All right, well, we'll get started. So Emily, what did your group have for describing the procedure? Or I'm sorry, defining, description or defining the procedure? Emily, not with, oh, there you are. Oh, Emily. Did you write it down or did somebody else write it down in your group?
We all wrote like all of our answers.
Oh, okay. So what'd you guys have?
For number 1?
Yeah,
Oh,
define.
communication?
Yep.
Or what?
Yeah, defining the procedure.
Oh yeah, we just put that it's like a surgical procedure that severs the vas deferens on both sides. That's pretty much it.
Perfect. That's exactly it. Caitlin, what did your group can help you too. What did you guys put as for indications, 1 advantage and 1 disadvantage?
I think we put, I didn't write it down, but I think we put like obviously to like prevent pregnancy.
Mm-hmm.
I'll go. Disadvantages we put was does not protect against STIs. Advantages is permanent and can be reversed and prevents pregnancy for an advantage.
You got it. You got it. So it's permanent, but then also it can be reversed. So it's a kind of like a catch-22, right? Procedure short, safe, and simple. Sexual function is not inhibited or impaired. So you want to let them know that, because sometimes that's a big question, is it going to ruin my manhood? And I'm saying that facetiously, but that is a question that some of the spouses may ask, or the partners may ask. So that's definitely something you want to let them know. And then Yesenia, what did your group have? And your group can help you for client education. I was looking for 2 teaching points.
So we put do not bathe or swim after having the procedure done, and to monitor for signs and symptoms of infection. But I also put have your sperm count done afterwards.
Correct. And did anybody want to add to that? That's good.
That's good.
Yesenia.
Yeah, I also put use other like birth control methods until the sperm count is reevaluated.
Good. Very good.
Some of the group said it's 20 ejaculations before sterile.
Correct. And then ice, scrotal support, ibuprofen for the pain and discomfort. Very good. All right, I'm going to share my screen again and we'll kind of wrap up. Let's see. There we go. I think you guys are good. I mean, I could give you a break, or you want me just to plow on? Keep going. All right. Okay, so the last piece I want to talk about is transitioning to parenthood. And there's just a couple of things I want you to know. And one of them is the maternal phases. So there's 3 phases, and your book goes into detail, the charts go into details and stuff, but what I want you to kind of get from it is the first phase is the taking in phase. The second phase is the taking hold phase. And the third one is the letting go. And I'll explain what they mean. So the taking in phase, the woman is in about her 24 to 48 hours postpartum, and she's more dependent on those around her, and it's more about her. And if you remember, that first 24 to 48 hours are the highest risk for postpartum hemorrhage. So it's probably not a bad idea. Nature probably designed it just perfectly so that she's in tune with herself. She's very dependent on others, including the nurse and the staff. And so she can recognize these small nuances and hopefully intervene before there's any issues. Another thing is she wants to recall her experiences. So you may see her talking to friends on the phone, family on the phone, and saying, what her labor was like. When did she go into labor? How long was it? What medications did she have? How large was the baby? How long was the baby? All those things she might want to be sharing. So that's your taking in phase. Then you have your taking hold phase. In the taking hold phase, she is now transitioning from it being all about her to being all about the baby. So now she is moving to more independence. She's focusing, her shift is now focusing to the baby and the baby's cares, the baby's needs, the infant's cues. She's taking all that in and kind of giving up that pregnancy role and taking on that mother role. One of the things you might see in that taking in phase is when the nurse comes in and brings the baby in and does her assessment, does the baby's assessment, and then goes to leave. And then she's like, oh my gosh, I'm being left alone with this baby. What do I do? You know, that's still in that taking in phase. Now over to the letting go phase. That's where she kind of lets go of and reevaluates her role in the whole family unit, or what, kind of leaves that fantasy of what it is, what it could be, what it should be, and kind of connects with if there's other children at the home, partner, kind of like gets into that whole family unit, and they kind of incorporate the baby into their lifestyle. So just to reiterate, taking in phase, she's very dependent and it's kind of all about her and she's reliving her experiences. The taking hold phase, now she's putting that focus onto the baby's needs, the baby's cues, the baby's care. And then the letting go phase is where they're now becoming a family unit, and it's kind of taking on a broader sense. Any questions on those three phases? Bonding and attachment, the takeaway on this slide is you're looking to see what kind of attachment does she have. I mean, there's the woman who was in 14 hours of labor and is exhausted and asked the nurse if she could take the baby back after she fed the baby to the nursery for an hour or so she can get a nap, is a lot different than the woman who, when they bring the baby in, you can tell she really doesn't want anything to do with it. She's not wanting to hold it. She's leaving the baby in the bassinet. She's prefers that the nurse feeds the baby, changes the diapers, and she kind of has a flat affect. That's a little more concerning than the woman who's just tired because she was, had 14 hours of labor and she just wants 1 hour just to close her eyes and rest. So you're kind of looking to see how is she interacting with that baby. And then the last part, family dynamics, we talk about sibling rivalry and ways, hopefully they're starting this during the pregnancy, and ways to make that transition smooth for the other sibling or siblings that are at home. And it could be having that other sibling come to the doctor's appointment when they're hearing the heartbeat for the first time, having some quality time and some time with the child, with the other children, letting them come into the hospital. Well, right now this will be pre-COVID, where they could come into the hospital and visit, and then the child would sit with mom and in the bed, and maybe dad or grandparents or somebody else could be holding the baby. Maybe they can have the child come in, and mom and dad or her partner could have bought some gifts and give the other children these gifts, and they don't have to be anything elaborate. Maybe it's just coloring books and crayons or a new doll or whatever they want. And just, that you're giving that and saying, this is from your baby sister, this is from your baby brother, and trying to get that bond and bringing the family together. And then this is just kind of talks about that pathway again, with those three phases: the taking in phase, the taking hold, and the letting go phase. All right, I'm going to go over these questions with you. So the first one, the nurse is determining a postpartum patient's amount of lochia. Hold on, your thing there. Okay, for which observation should the nurse document a moderate amount? What do you guys think?
Is it 2?
Okay, good. Now think about, remember those normal changes that occur. So everything's going along fine. The nurse reviews the labs illustrated below from a client who's 3 days post-delivery. What should the nurse do in response to these labs? One, correct. So they're pretty normal. The white blood cells, remember I said they can get as high as 30,000. The laboring client in the first stage of labor is talking and laughing with her husband. The nurse should conclude that the client is probably in what phase?
Latent.
Latent, good. The nurse is caring for the client in labor. Which assessment finding would help the nurse determine whether the client is in the third stage of labor?
1.
Correct. Lengthening of the cord. The laboring client is experiencing dyspnea, diaphoresis, tachycardia, hypotension while lying on her back. Which intervention should the nurse implement immediately?
1.
1, correct. Turn the client on her left side. And any questions? Let me just look at the chat here. Oh, okay, you're answering the questions there. So everything from module 2, the 3 PowerPoints, the 3 lectures are on your exam. Your exam is next Wednesday from 4 p.m. to 7 p.m. You have your whole time for it. No lecture afterwards. You have the study guide now posted. All that stuff. I want to just go over CLGs, and this is just generally to everyone. Just make sure that they are they're nursing articles. So make sure it says nursing in. They're nursing articles. They're less than 5 years old. If you're having trouble finding articles, Rick Paterick is amazing to reach out. He's also very good if you are working on your group project and you're trying to find articles. He's really good. Just I wouldn't wait till the last minute. You give him a little bit of time to come up with some articles for you. Every now and again, students are working on a project, on a group project, and they cannot find any current literature on what they're studying and what they're working on. So then what I do is say, reach out to Rick. Rick will look and see if there's anything current on your topic. And if there's not, he will send you an email and he'll CC me saying, this is all that I have. And maybe it's 7 years old or 9 years old. And in that case, I say, okay, as long as you guys reached out to Rick and he said, nope, because he's really good at researching articles. And if he says, nope, this is everything that I could get, then I approve of it. So, but you just make sure that you reach out if you're having trouble trying to find anything. The clinical schedule change does not affect you. That was something for the day group. You have a beautiful clinical schedule. And then the group project. So I wanted to wrap up early. I did, so that you have time if you want to work in your groups on your group project. I posted 2 new samples. So somebody asked me about a paper. So I thought it might be easier to see a sample PowerPoint with the exact same paper versus putting a paper that doesn't go with the PowerPoint. So I took their names out. I posted those under your project. So you should see the paper and the PowerPoint. It's on Pika, P-I-C-A. And the only thing I want to remind you is I change my rubric a little bit every year just because I say, oh, you know what, that didn't work, that did work. So I always revisit it. So make sure that you follow the rubric and you'll be good. And then, I mean, the ones that I posted are good, but they're not 100, like they didn't get 100. They might have maybe messed up on a citation or something like that. It was definitely an A+. What I give you is A+ work. But it may have like 1 or 2 little things. But other than that, I think that should be helpful for you guys. Were you all able to see that? Or maybe you didn't look at it yet, and that's okay.
Professor Gannon, I saw the announcement, but when I went to go click on the files, I can't open them and I can't find them within the Canvas shell either.
Me too.
Okay.
Yeah.
Let me stop recording.